Good afternoon, everyone. I'd like to welcome you to the second session of the Beyond Prescribing webinar series. My name is Andy Romero. I'm the project manager at Health Insight, working on this project with the New Mexico Department of Health. If you were unable to attend the first session, the recording and the tools have been posted on the Health Insight webinar, the website. And we're going to go ahead and pull that up for you right now so that you can see what we have out there for you and how to get there. So when you go to, Shannon has dropped a link to the website in the chat, but when you go to our website, if you just go to HealthInsightorg and you go to healthcare professionals, you'll get a drop down. If you choose nursing home, then you'll get another drop down and you'll see antibiotic stewardship in New Mexico nursing homes, and that will take you to this page. And on this page, we have an introduction to the project itself. We have some helpful links that might take you to other areas of our website that might have good information. And then when you go down to the page, you'll see each of the webinars will be on the page. And within the webinar section, you can download and view the previous webinar. And what we'll be doing in addition to that is the Q&A session that we're not posting. We'll be summarizing that and posting it as a Word document in this section. And then any tools that we have for this project will be posted under the tools link, and you can just come out and download and view the tools. So you'll have access to everything that we talk about or use during this series. This session has been approved of 1 hour for continuing medical education. And this slide and the next just show you that our speaker, Dr. Kelly, and our planning committee, Ann Timmons, Shannon Kupka, myself, and Elaine Villa do not have any relevant financial relationships to disclose. You will be able to get credits for CME at the end of the series, which ends March 28th, 2019. So if you are planning to apply for CME, be sure that you have entered your name in the chat. This session has also been approved for 1 hour of continuing education for nursing home administrators. And again, make sure your name is entered in chat if you're going to be requesting the nursing home administrator continuing education. We are excited to have Dr. Kelly back with us to facilitate today's session. Dr. Kelly was on the faculty of the Department of Internal Medicine at the University of New Mexico from 1999 to 2017 in the Division of Infectious Diseases, serving as hospital epidemiologist for UNM Health Sciences Center and the New Mexico VA healthcare system. During this period, she worked on response to pandemic influenza, bioterrorism, public reporting of healthcare-associated infection, control of multi-drug resistant organisms such as MRSA, and response to emerging infectious diseases such as Ebola. Dr. Kelly has also served as the leader of statewide multi-hospital collaborations for control of MRSA, central line associated bloodstream infections, and Clostridium difficile. She retired as Professor Emerita in 2017. She continues to serve as a consultant to agencies in New Mexico working to reduce healthcare-associated infections and improve antimicrobial stewardship. So at this point, I'm going to go ahead and turn this presentation over to Dr. Kelly.
Hello, everybody. Thanks for tuning in. As you remember, the last time we went on, we started on our journey here with some background as to why we need antimicrobial stewardship in long-term care, resistant organisms, patient harms, and we talked about the beginnings of the elements of stewardship that you need to have in place, especially leadership, accountability, and some expertise among your personnel, whether it's a pharmacist or a physician with some knowledge of antibiotics. So this time we're going to start digging in a little deeper and putting you to work. So today we're going to show you how to perform a gap analysis of your current activities in preparation for stewardship and either map a process for decision making about antimicrobial use and or perform a point prevalence survey of antimicrobial use, and then use information from one of these investigations in your facility to plan your intervention. So this sounds very dry, and I apologize for that, but you really aren't going to be able to make improvement until you have a deep understanding of what goes on in your facility. And that means not just what's written in the policy, but what is actually happening. The gap between what's written in the policy and what's actually happening can be huge. You take it from someone who worked in hospitals for a year, right? And saw that happen all the time. So you're going to look and explore your current state with honesty and clear eyes. And really, that's the way it is. And the more you know about the current state and don't try and fool yourself that it's better than it is, or that things are being followed, or that you have things in place, the more effective your plan will be, because you really will be addressing reality. So you have a desired state, which is where you want to be with your antimicrobial stewardship, to have a program. In between is a large gap, and from that gap and understanding that gap will create our action plan. So there are two levels of gap analysis in stewardship, and we're really only going to deal with the first today and leave the second until the next webinar. Now, everybody should have had a copy of the core elements of antibiotic stewardship for nursing homes checklist, which is a CDC document. It's very nice. It's a 3-pager with really only 2 pages of content, but that content is extremely dense. And each element here actually requires a lot of work. So what we're going to do is break down this content into 2 sessions, starting with the structural gap analysis today, and then the activities analysis, doing things to actually improve prescribing for later in this program. So today we're going to be concentrating on, do we have the tools, personnel, and structure to start the program? And then later on, we're going to be looking at, do we have some evidence-based activities to make improvements in prescribing? And is that program sustainable? Do we have meetings scheduled? Are we moving forward from month to month? So one of the frustrating things about stewardship is that it's really a process. Nobody can really tell you exactly what it is going to be for your facility. You are going to be exploring this process and making it up for your nursing home as you go along. So let's talk about structural gap analysis. Let me just go back and show it. Okay. Structural gap analysis. Do we have the appropriate personnel to review cultures and drugs? Somebody with infection prevention background may be able to review cultures, pharmacists to review the drugs. Infection prevention background actually has quite a lot of microbiology. You can see that you may have a susceptibility problem in your culture results. Have we identified ways to communicate to our staff and prescribers about antimicrobial stewardship activities? Do we have our poster? How do we get out the results of our work and our explorations? And then data. Do we have sources of data on how much of a particular drug we're using? How many doses? How many patients are on drugs? Can we generate reports of infections meeting criteria for healthcare associated infection, culture data, and very ambitious now, antibiograms, which we'll get to further down the road. So this really has to be a data-driven enterprise. So you have to have some evidence that you're looking at data regularly, using a denominator that is consistent. So you have some kind of denominator, so you have some kind of rate, and then following that over time as you do some kind of intervention. That's really the bottom line of what CMS is going to want to see in your facility. So here are some of the elements. that we need to have in place. So this is our first polling question. Our facility has a multidisciplinary group that meets regularly to review data and plan interventions in antimicrobial stewardship. That sounds like a desired state. Is anybody at the desired state? Yes, we have some people at the desired state. Good. Other people know they are not at the desired state. This is then a gap. Not everybody has clicked. Okay. So we've got some gaps. Nobody feels super strongly agree about this. So maybe you just got started, you know, so you haven't really seen it go on for any length of time yet. So we have some people where it's a gap. Are we stopping? Okay. All right. So there's a potential gap, basically creating a committee and scheduling regular meetings. So next polling question. Okay, all right, next slide. Not on the slide right now. Okay, let's see. Oh, you're gonna have to click on the slide for me. Elaine, here. Click on the slide. Okay, all right. Okay, polling number 2. Our facility has identified consistent and reliable data sources to use in an antimicrobial stewardship program. Some people have, other people, it's a gap. So what are your data sources going to be? Are they electronic microbiology reports? Is it a binder full of lab printouts? That's okay. We often have to work with paper and then get it onto an Excel spreadsheet. Okay, so some people are very strong in their data, and then we have other people where data gathering is still a gap. Okay, I'm going to go to the next slide. Okay, let me go on to oops. Polling number 3. Our facility has identified ways to communicate, okay, to staff and prescribers about antimicrobial stewardship activities. Do you have a newsletter? Do you have a notice board? Do you have a regular staff meetings, huddles, interventions of that nature? So we have actually pretty good communication, because I'm sure that there's lots of communication already going on about things like pressure sores, other elements of resident well-being. So think about it. Could you use that same structure to communicate about antimicrobial stewardship with staff? Okay. So move on to the next slide. Okay. All right. So what kind of things do people need to complete this structure for antimicrobial stewardship? Remember, we're talking about a committee, some expertise, and a way to communicate what we're doing to our staff and our prescribers. What are people encountering? Where are the barriers? Are you having issues getting data for review from a pharmacy or your contracted lab? Anybody want to describe a gap that they found that they feel they need to fill in how they approach antimicrobial stewardship? So we have a couple of things to get you started in terms of materials. The first thing is this sample antimicrobial stewardship policy. Yeah, let's pull it up and take a look at it. Yeah, never hurts to start with a policy. So one thing that you'll see when we get a little deeper into the CMS requirements is they do want you to have a committee that is purely devoted to infection control and antimicrobial stewardship activities, i.e., you can't just be rolling these into another QA committee. So this policy came from a publication, which is the Journal of American Medical Director Association, quite recent, 2017, and template for a stewardship policy for post-acute and long-term care facilities. I edited it down and simplified it quite a bit. So what you'll see here, and this, you may be in a facility where you have a policy provided to you by some corporate entity, or you may have some kind of template or format that you have to use for your policies, but this can then be adapted and cut and pasted in. So what does the policy intend to do? It establishes how we're going to do stewardship and set up our committee. It's going to be part of the infection prevention and control program. This is what CMS wants to see. The infection preventionist is an integral part of it. And then you have these other critical personnel, the director or assistant director of nursing, a medical director or other designated physician or prescriber, and then a consulting and or dispensing pharmacist. So the actions that are required of the committee is to support and promote antibiotic use protocols. Some of our facilities already have these protocols provided by corporate owners, but really if we just start with one protocol, that's enough to be starting with. So don't be intimidated by, well, we have to have all of this all at once. Develop and maintain a system to monitor antibiotic use. Review the antibiotics, review a subset of antibiotic prescriptions. So that's actually quite flexible. Maybe you're just going to look at your data and decide to look at one antibiotic. Maybe we're seeing just a ton of, say, fluoroquinolones used in our facility, like Levaquin, Cipro, something like that. And we just want to focus on one antibiotic to start. So scroll down a bit more. At least annually, do some kind of feedback to your facility. Develop and maintain a system to monitor resistance data. You may already be doing that as part of the infection prevention program. Looking at lists from your lab, do you have MRSA, resistant gram negatives in urine cultures, E. difficiles? Throw that into the annual report. So the annual report is very useful when you have staff turnover so that you can demonstrate some continuity of your program. So you're going to provide education at least annually. We'll get into what that will consist of later in the program, and support dissemination of materials to residents, family members, friends, and the resident and family councils. So you'll let your constituents and the people that you serve know what you're doing. And again, those are all materials that we can provide. And you meet at least quarterly to look at your data, review your activities, and look at what other committee members have to share, something they've noticed when they've looked at their data, perhaps through review of medications by your pharmacist, or review of infections by your infection preventionist, and review progress on your action plans. So we went through the agenda for the committee last time, and how to create that agenda as you go along and bring people together. And this just formalizes how you do that. And one of the things about having a policy is
if you're going to use a policy, edit it, adapt it so that you are really following the policy in real life, and you can demonstrate that by your scheduled committee meetings and by what's on your agendas. So the other materials that we have, let's just go back to that slide there. Okay. Other materials. Okay. The gap analysis tool is just another Word document. And this is to start you thinking, yeah, there it is, okay, about what you need to do. So, again, do we have a leadership commitment statement? We provided that during the last webinar. That's something that's pretty easy to adapt and then disseminate to your prescribers and residents. The poster for the facility, we are working on that here at Health Insight, and coming up with a poster that you'll be able to adapt to your facility and put in your name and a picture. Do you have job descriptions made up yet for what people are going to do? We provided that template at the last webinar as well. Accountability, do we have antimicrobial stewardship written into role descriptions for the pharmacist, for infection prevention, for nursing, and so forth, for our physician medical director? Have we scheduled this meeting? Do we have the policy? We just provided that. Do we have a meeting format? We provided the agenda at the last webinar. Scroll down a bit more. Do we have the appropriate personnel to review cultures and drugs? Do we have ways to communicate? And then data, do we have sources of data? So looking at all of those materials, are there things that people are finding challenging, or does breaking this down in this way make it a little more approachable for participants to get started? Any comments or chat?
Nothing in the chat right now.
You can type in. Once you get started on this process, it starts to happen. Just looking at data is, in fact, the first step in antimicrobial stewardship. So let me go on to the next slide and we'll talk about data. Where do we get it? And how do we get started? Okay. So we need to understand the prescribing process in our facilities. We also need to, while we're being data-driven, remember the human aspect of this and just how powerful it is to motivate our staff and prescribers with patient stories when we find that there have been issues with antibiotics, and then generate your own facility data. It's never very helpful at any level of healthcare when you're dealing with prescribers and staff to say, oh, you know, C. difficile is so high everywhere in New Mexico, whatever, and in the country it's a huge problem. People want to know about your facility. Even if you have only a few data points, it's immensely more meaningful. Like our surgical rates, how are we doing? And generating your own data really speaks to your staff. So why do we need to go deeper? We really need to decide our priorities. You need to find out what the big issues are, and even a small action on a big issue will often yield a big result. So this will help you decide your priorities when you start to deep dive into what's happening. Understand how prescribing takes place in your facility and where change is possible. As you go through your processes, you'll see there are some things that are easier to change than others. And that's very facility specific, and you'll have to make that determination. You'll generate your own data that you're going to look at and follow over time, and you'll ask the right questions when you have a good understanding of what's going on. And as you gather your data, you can get insights at two levels. You get insights from aggregate data, which are your rates. We use 10 prescriptions of ciprofloxacin in the month of May when we had 900 patient days, because we had 30 patients in for 30 days is 900, right? And then you can calculate a rate. So that's an understanding from aggregate data. But then close review of individual patients can give you insight into not just the what, when, and how many, but the why of antimicrobial use in the facility. So so-and-so wrote in the chart, I'm using this because, and you'll think, well, maybe that's not such a great because. Is it really justified? Why was it prescribed for 10 days and not a shorter length of time? So then you start to get a better understanding. So here's one tool that you can use to look at the decision-making in your prescribing. Follow a single patient and see how the prescription of an antimicrobial happened, right? Did it start with a change in patient status? Who communicated to whom here? Whom, I should say. And then look at that process. Do we have tools for structured communication? Tools for accurate assessment of the patient, and any kind of early intervention to improve status without antimicrobial? What happens? The family says, oh, mom's urine is smelling or looking not so good. What kind of cascade of events happens after that? Do we have anything in place where we might say, she looks like she needs better hydration, has not been eating or drinking much lately, and so forth. Then once the RN knows this situation, what then happens to the prescriber communication? What gets communicated to the prescriber? How is it done? Is it done by a fax? Is it done by a phone call? Is there some kind of process in place where there's a pre-ordered, say, culture? How is that culture obtained? So just looking at one patient in real detail, you can start to understand stuff. And then the use of antimicrobials by the prescriber. How does it happen? Does it happen based on what you've got there on the unit in your emergency kit? Are they accessing any kind of guidelines or structured order sets? How much do they know about the patient? Is this a patient who gets treated over and over, month after month, and may have resistant organisms now? Do we know what formulary this prescriber is using? Do they know what the results of any cultures are? And so just looking at one patient and asking these questions can yield a lot of opportunities for improvement in prescribing. So why map this out? Let's find out what tools are in place already. What are people using? Is this really uniform in your facility? Or what often happens, are they supposed to be using something, but they're not? That's also important to know. Where could we intervene to improve prescribing? Are we stocking too many choices, say for urinary tract infection drugs at the facility? Are we communicating effectively, whether it's electronically, fax, paper results, printing out, or phone call? Where could we improve communication? Is there a long chain of communication? Is it slow? Are weekends an issue? And where could we improve training on obtaining cultures, for instance, and making sure those cultures are, say, immediately put in the fridge and picked up promptly? Is the Foley changed before a urine culture is obtained from a patient with a long-term indwelling Foley, and so forth? So the other part that you may find here as you dig in is, and listening to those other members of your team who are doing this, is what drives your prescribers. There's often a profound need to do something immediately, and a fear that they will not be notified if the patient's condition worsens, and a lack of context and having complete information about the patient. And that can certainly be improved by having a good structured tool that really gives them all the assessment points that they need. Now, just to give you an example, I would always say, when I was teaching with the residents, the urinary tract, the catheter-associated UTI is the intern's favorite infection of all time. Why is this? Because if you have a patient who's got a catheter in long term or for any length of time, the urine culture will be positive. The intern is called, they order a bunch of labs, often without even seeing the patient. The urine culture comes up positive. They feel tremendous job satisfaction, and that may lead to a complete miss of another diagnosis. So we have to make sure that patients are getting complete assessment and that there isn't just this reflex need to do something immediately that sometimes actually puts people on the wrong track and leads to a misdiagnosis. So the other problem with prescribers, and certainly in acute care this was an issue, there's a reluctance to wait for all the results and have to track or follow up on a patient or turn over care to another clinician. So we have to think about, do we have ways so that patients aren't lost as we wait for results to come back, so that we don't just all the time? Providers are getting a lot of different information about things like sepsis and so forth. A lot of pressure to prescribe. Is this always right, or are we doing more harm than good? So the other problem with prescribers is they usually operate in a 4 to 8 hour time frame in their thinking, and they never ever get any kind of feedback on their prescribing practices. So by that, I mean nobody ever tells them, whoa, you prescribe 3 times as much as another person, and the outcomes are sort of the same for the patients, so what is going on? So there are definitely prescribers that are outliers. Habit is very powerful. It's very difficult actually to change what you learn during your training, which may have happened at various points in the past. But seeing inconsistencies in practice is certainly a hint that things are not being as evidence and data driven as they should be. So do any of our participants have structured assessment and communication tools in their facility? How are these being used? Who has standardized order sets or clinical guidelines? And do you know if they are being used consistently?
So while we're having people go ahead and type in their chat,
Yeah.
We do have some comments in the chat.
Okay, good.
So the first comment says that one of the challenges is just knowing where to start.
Right.
Is a hard part. And so the participant said, yes, definitely some of the ideas that are being presented are very good places to begin. Then we have somebody saying, I think getting everyone on board is the hardest, and getting the physicians to understand that they cannot just give antibiotics unless there are proper diagnosis and the infection has to meet criteria.
Right. So what sometimes, I think I said this the last time, we do have to go through the stages of quality improvement, right? And I'll get the stages wrong again. But, you know, you have to present them with their data, undeniable data, and say, look what happened to Mrs. So-and-so. We'll get into this a little bit later. But look what happened to her because of how this antibiotic was prescribed, right? Nobody knew that she had just finished a course of antibiotics and had just come out of the hospital where she had had C. diff, and then she looked a little bad and they just put her right back on something, and bam, she got C. diff and back in the hospital. So that's a powerful story, but you also have to back that up with, if we had looked at our guideline or looked at all the data and saw her recent history and had assessed her a little better, maybe we wouldn't have had to use that second antibiotic, right? So this is where your data deep dive starts to be very powerful, is to find out what's really happening to your patient.
Another comment is, my provider will not order a UA without at least, I believe it is 3 symptoms of a UTI. He states this is because of antimicrobial stewardship. I don't see the harm in testing. What would his reasoning be?
Okay. So here's a provider wants not to order a UA until the patient has 3 symptoms of UTI. That's actually very reasonable. So what you have to realize, what can be so difficult with elderly patients is there is a fixed rate of asymptomatic bacteriuria. So if you take patients over the age of 65, in women, it starts to go up with age. I think they start out at 20% and then they get up to 50%. You will get a positive urine culture with no signs or symptoms of urinary tract infection at all. So all you are finding is false positives. So in order for that urine culture to be meaningful, you have to have some other criteria for a UTI, such as the bladder tenderness, some fever, some altered mental status, and we'll get into that later, but that's really very reasonable. The more urine cultures you send, the more positives you'll get, and you have no idea if they are real UTIs or not.
So some of the tools that they're using, e-Interact. We do have a change in condition form, but it is not being used prior to contacting the provider. It is more of a fill in the form after the fact because it is supposed to be done.
Right. So we have to look at some of these tools. I'm not sure what e-Interact is, but we have to see if there's a reason that they're not being used. Do they work well? Is it a lack of education? Are they too cumbersome? This is often the case with tools. Can they be stripped down?
E-Interact is a change in condition form.
E-Interact is a change in condition form. Good.
Somebody else says they need a dedicated group specific for infection control.
Right. So if you look at the CMS survey that we'll get into on the next webinar a little more, it's pretty clear that you need to have a separate committee that addresses infection control and antimicrobial stewardship in one committee. You cannot tag these onto another group because you've got to be in this mindset of thinking about it, and you've got to spend some time looking at the data.
Let's see. Somebody else says we've had a change in medical director 3 times in the last 2.5 years, and not having a consistent provider has been a challenge to make any changes.
Right. That's where having your policy and writing down your agenda and what happens at each meeting is really important, so that even when those people drop out, and you are waiting for a replacement, you can keep your committee ticking over. You may not be able to do the same level of analysis as you could with a provider, but you will be able to continue looking at your data and at least doing some work in your committee as you go forward. There's always work to be done. So I'm gonna just go ahead now. So a lot of you have probably heard of root cause analysis. This is now being updated a bit to system analysis, because it was really realized that in healthcare, often we don't have a single root cause. We have many, many causes of, say, adverse events. So this is kind of like the process map, but in reverse. You start with an event that has a poor outcome, a missed culture result, a failure to review susceptibility data, adverse drug event, and then go backwards from there and see why this occurred. It helps, if you're doing this for just to explore, you could do it on any adverse event. If you're doing it to try and improve your system, it really works better when you have some control of a problem. I'll give you an example here. Central line associated bloodstream infections used to be pretty common. And then we started with a bundle and putting them in with full sterile technique and so on, and using chlorhexidine, and the incidence dropped dramatically. At that point, when we had our overall process in place, we used the root cause analysis or system analysis to look at the failures. So whenever we had an infection, even when we were doing the bundle, what happened? And that gave us more insight into things like, oh, when the patient had an emergency line placed in the OR, there was no way to communicate that to the ICU, so that the ICU did not know that they had to replace that line as soon as they could. So the other things that you're doing with the root cause or system analysis is you really want to get very close to those people on the front lines of care, because they will tell you when your system is failing, your system that you thought you had, right? The forms that you thought you were using, they'll tell you why they don't use them. They'll tell you the workarounds, and also you will generate very powerful patient stories when you do these root cause analyses that are actually great for motivating your staff and explaining to them why the work that you're doing is important. So when you investigate with your root cause form that we'll go over within a second, remember from that diagram that I had in webinar 1, social cohesion or trust is a huge factor in healthcare. When you have an adverse event, is almost always a breakdown in communication. Trust is very important. So if there's an issue, address it. Don't think this is like soft data or not good data. It's actually a very important thing to address if people can't communicate or if there are personnel issues. So this is how you get to the whys and the feelings that surrounded the action. So these are things like, she was new, so, like a new staff member, or I didn't want to bother X again, right? Because maybe X is nasty. The family members were really upset because it was a weekend, there were no results until. We didn't see the rash until, right? Because the patient only got flipped over every other day or something like that, right? So this is the kind of information that you get when you talk to your frontline staff, and it's really very rich, valuable information that gives you a clue that maybe people aren't comfortable speaking up, which is one of the biggest causes of patient harm. So let me just go over the document actually. Let's look at the document first before I go on to that. So here's this is a very standard, I think this comes from AHRQ originally. So this is just a form to write down what happened with an adverse event. They call it root cause analysis still here, not system analysis. Looking at your what, who, when, where, how of the event, and then scroll down a bit, looking at fixable and non-fixable things. Identify what you think will have the greatest impact, but don't forget about all the other rich little issues that you found when you delved into this, and talk to people about what happened with the resident. Then on the back side, scroll down, list as many possible contributing factors as you can think of. All of these are standard. When we do a fishbone diagram, we look at where was the lapse in communication, care management, knowing about the patient, their records. Did we not have policies or procedures in place for this? Physical environment, staff education was lacking, equipment failure, individual resident needs, was there supervision issues? And then look at all of the possible contributing factors, things that sometimes you can't fix related to the resident, but other factors, other sources that might have additional information. And then you can always dig down through the problem using the 5 whys method. Why did that happen? And why did that happen? Using like a 5-year-old, why? And ultimately you get to sometimes this really crazy answer as to what was the root cause, or some kind of fallacious assumption that set this whole thing in motion. So while you're generating this, let's go back to the slides. All right, there we go. So, yeah, I don't know. Yeah, we'll exit this. So while you're generating this, think in narrative format. Because, here you go, here. Okay. Are you clicking on there so I can go? Okay. All right. So narrative is very, very powerful in healthcare, and we've often used stories to get things across. When we're talking about patient harms, my favorite writer, Joan Didion, we tell ourselves stories in order to live, to really make sense of what we're seeing. And then Rita Caron is a physician who basically invented the term narrative medicine and showed that it was very good for bringing together teams, because when you told the story about the patient, everybody could participate without the power hierarchy that usually governs who gets to lead a meeting or who gets to talk, because everybody has a story to tell about their relationship with what happened with that patient at whatever professional level they interacted with the patient or the resident. So next slide. So this narrative can be something that you can tell over and over to motivate people. So have people used root cause analysis or systems analysis as a QA tool? Has it been helpful? Do you do this as part of QA ever? I don't know if we're getting any feedback chat. No. Okay.
Yeah, nothing related to this.
Okay.
We do have one other comment about our PCP has frequently ordered antibiotics when they ordered the initial UA and orders antibiotics pending culture results. I send the monthly infection control report to our PCP, and staff have been informed and educated to question this.
Yeah, good. Okay. So UAs, of course, are big, and we have to look at. So that's when you get into your data, if you find somebody who has an adverse reaction to an antibiotic that's very useful, you should be looking at adverse drug events as part of your QA, and that can be another source of data. But I'm going to move on a bit now because we don't have that much time left. Can you give me a click? No, I need, okay. This is the numerical side of the data, which is a point prevalence survey. You can look at how many antibiotics are on, so how many residents are on antibiotics during a given time period, single day, week, or month, and then capture some specific information about those residents and why they got antibiotics. Let me get, okay. So why generate and present your own data? All clinicians tend to think they're doing better than they really are, right? And prescribers actually love aggregate data. They don't get it. They just don't see this, and they don't track their own prescribing. So if you actually provide this to people, they're usually very appreciative. If you do this point prevalence survey and repeat it at regular intervals, it will fulfill your CMS requirement for ongoing data collection and analysis. And it can be scaled up to whatever your size of facility is. So you could include data on residents who come in already on an antibiotic, and that would enrich your data as well. So different ways of looking at this. Let me go to the next. Okay, again. Okay. So how are you going to do a point prevalence survey? Select a date. You don't want it to be like right now that you start looking today, because you are going to want to be able to look with some forward and back chart review to see how cultures turned out and so forth. Find a date, look at all the patients who are on antimicrobials on that date. This may entail just going to the MAR, may not be that easy. Try to have at least 5 to 10 subject patients. If you can't get 5 to 10 subject patients in a single day, then say we're going to do a period survey a week or a survey a month. You may have to do this on a monthly basis. Yeah. Go to the next one. There we go. So where we get a little math nerdy is we want to have some kind of consistent numerator and denominator. So if you're doing it for one day and you have a pretty big facility and you had 6 people on antibiotics on one day, then it's pretty easy to generate, oh, that day we had almost 11% of our patients on antibiotics. And then you could compare that over time. If you don't have a lot of antibiotics in a single day, look at a month. What was your average daily census? 58 patients. There were 6 separate antibiotic courses given. Each was 7 days. So then you had 42 antibiotic treatment days divided by 1,740 patient days, or 2.4 antibiotic days per 100 patient days. So this is also a metric that you could repeat over time, and you've generated a denominator, which is patient days, which is consistent. So you're showing that you're really going to be able to see change. And for any of our individual facility QA things, the bottom statistical line is that you really need a sample size of 35 to 40 to see change, but you're not going to gather that for a few months or years. So often, you can't get excited about it. You're just going to go forward, and your data will be unstable and jump up and down until you start to accrue some more numbers, and it just takes time.
So the comment is, would that not be 1,000 patient days?
Well, you can have a denominator. No. 42 divided by 1,740 is 2.4 per 100 patient days. Yeah.
So to get the patient days, did you multiply the 30 by 58?
I multiplied the 30 by 58. Was I wrong with that?
I don't think so.
I don't think so. No, I no. You know, we use different denominators. You could do, it would be 0.24 per 1,000 patient days. I know that a lot of people are used to using 1,000 patient days out there for their C. diff, you know, or other antibiotic, other infection control metrics. But basically, you can make the denominator whatever you want to get a number that's kind of nice, you know, like something close to an integer.
A couple of comments are that
Yeah.
they use 1,000 patient days
Right.
and it's coming from their system.
Right. So yeah, if you want to do the 1,000 patient days, and that's the way your system is, this would generate 0.24 antibiotic days per 1,000 patient days. And maybe that's a better way if you're looking at, say, your counties or your C. diffs, and that would make more sense to you. It's true. So we provided, I'm not going to get into this in the last 2 minutes, we provided a tool for doing the point prevalence survey. Maybe we should get into it. Okay. So yeah, we just have the patient identifier, any other data that you care to collect that may be relevant for antibiotics would include their weight, age, any creatinine if they have renal insufficiency, any devices in place, the drug that they got, what was the dose and the frequency, was this properly adjusted, the drug duration, was it even put in the record, did the record note the treatment site, was there a rationale for use information stated in the record, were the cultures obtained and results, other outcomes. So you can see just getting the data on one patient, you can generate a lot of rich data. You don't need big numbers. Just looking at a few charts a month, if they have that available to you, helps to find out what's going on. Opening a few charts is how you get started. So what might your report look like to your committee after you do look at a few charts of patients on antibiotics? On this date, we had 10% of our patients on antibiotics. 2 of the 6 had inappropriate dosing based on weight and creatinine clearance. The duration ranged from 1 to 3 weeks. A third of them had no rationale. 1 was transferred from the hospital, an antibiotic. There was no stop date in the chart. And we saw that there was drug-bug mismatch, i.e. the culture came back resistant to what the patient was getting, and then the antibiotic had to be changed, and then 1 patient got a rash. And that's 6 patients and a lot of interesting data there and a lot of scope for improvement. So just to wind up, which of these types of assessments do you think would be most useful for you? You are going to have to do some homework of some kind to get started, because any one of these is a form of data collection that you can present to your committee and discuss. Looking at aggregate data, doing a deep dive on someone with an adverse event, or just looking at the decision-making process on any single patient is a point to get you started and have your committee start to generate some ideas or get some priorities. If you're lucky enough to have large data reports available to you, maybe you might want to pick out a single drug and then look at just doing a prevalence on an assessment of all the patients who got that drug for the month and what was driving that decision making. So in preparation for the next webinar, we want you to perform the gap analysis and take any actions that you need to do to complete your team and start to get access to some kind of data. Gather some of your own data in a way that will give you some insight, not just numbers of doses or numbers of the drugs, but gather some data that will give you insight into what is happening with the decision-making process, and then have a discussion about the findings and record it in the minutes of your committee. So does this help you prioritize where you're going to go next? So this is what we want you to do before December 20th. Does that seem feasible? Any comments?
No comments.
Okay.
So it does, yes, everybody's saying yes.
Good.
Seems to be.
Okay. Yes.
Hopefully,
The
thank you
first
so
step.
much.
The first step. Yes.
So we are running out of time, so we're not going to have a lot of time. We're not going to have any time for questions and answers today, but if you do have any questions, feel free to email them to Elaine or myself, and we will get them to Dr. Kelly and get back to you with the answers.